Ladies and gentlemen, dear colleagues, I would like to thank you one more time for your participation in our course. Today, my topic is the intranasal trigeminal function, a relatively unknown field in our specialty. In my lecture, I will give you some aspects of anatomy and physiology of the trigeminal nerve system regarding its relation with olfaction, with nasal airflow, nasal defense mechanisms. Of course, we will present the ways of its clinical assessment and the related nasal pathology with the trigeminal nerve system. Trigeminal nerve is the largest of all cranial nerves. Distal to the trigeminal ganglion divides in three branches, mainly for nasal mucosa. We are interested for ophthalmic and maxillary branches innervating the anterior and posterior part of the nose respectively. There is no doubt that trigeminal nerve is in close relation with the olfactory system and interacts with it in several levels, from brainstem to olfactory bulb and the olfactory epithelium. Please notice that the trigeminal nerve innervates the whole nasal cavity, including the olfactory epithelium area. When we say that I can smell something, this is coming from simultaneous activation of the trigeminal and olfactory system, meaning that most odorants also stimulate the trigeminal nerve. And at higher concentrations, it seems that odor sensation is suppressed by the trigeminal system. So trigeminal fibers can be directly activated in nasal mucosa. Several receptors process chemosensory information independent from olfactory system. And most of them belong to the transient receptor potential family. And these receptors are sensitive both in specific temperatures and specific chemicals. A classic example is the receptor TRPM8, which is activated by mint and also by quite low temperatures, giving a sensation of freshness and coolness. On the other hand, the TRPV1 receptor is activated by chili pepper and fire temperatures, and this is giving this sensation of burning in our nose. So till recently, we knew that one of the main differences between the olfactory system and the trigeminal one was that the olfactory has its own olfactory bipolar cell, which is the chemosensory cell. And on the other hand, the trigeminal had only free endings at the nasal mucosa. However, this is not true because recently we found that we have some solitary chemosensory cells in the surface of respiratory mucosa, not only the nose, but also in the lungs. They resemble taste cells. They reach the surface of the mucosa and express bitter receptors of the T2 receptor family. So the difference between the free endings and the SCC's cells is that free endings stop at the level of tight junction. They can be reached only from stimuli which can pass this barrier. However, the apical end of the SCC is crossing this barrier, so giving the opportunity in a broad spectrum of chemicals to reach and connect with the apical end of an SCC. Some microbes secrete some bitter peptides, activating the T2 receptors in the surface of SCCs. In here we have the example of Pseudomonas aeruginosa, and we see that activation of the T2R receptor leads to intracellular release of calcium ions, and this leads to activation and production actually of NO. Then NO acts with both ways. One, increasing the ciliary beating, and second, can kill directly the bacteria at the level of nasal mucosa. In general, we can say that a variety of stimuli can activate the trigeminal nerve. This activation has two ways of acting. One is the orthodromic, and then through the brainstem, we have activation of the autonomic nervous system, leading in rhinorrhea, vasodilatation, and plasma exudation. However, there is the antidromic also way, the so-called axon reflex, with direct secretion of neuropeptides like the substance P or the CGRP peptide from the nerve fibers directly to the glands and vessels, causing the same symptoms. So summarizing the trigeminal nerve functions, we can say that it contributes to somatosensory, chemosensory perception, is a part of neurogenic inflammation, activates the autonomic nervous system, and of course takes part in remote reflexes like the nasonasal, nasocardiovascular, and nasobronchial reflexes causing cough and sneezing. Of course, the trigeminal nerve is a multimodal nerve with multiple functions. However, we shouldn't forget that the intranasal trigeminal system acts as a sentinel of the airways and actually is involved in detecting and clearing of inhaled harmful substances. Odorants can stimulate somatosensory system through polymodal nociceptors. What we feel after activation of the trigeminal nerve is touch, cooling, stinging, burning, and pain. And this sensation coming from afferent fibers. Usually stinging is coming through the alpha delta fibers and burning and pain through the C fibers. Talking about the localization of receptors, now we know that the mechanoreceptors are located in the posterior part of the nose and the chemoreceptors in the anterior. In general, the anterior part is significant and more chemosensitive uh, compared with the posterior. And this is important because what we feel as nasal patency is coming not from the nasal resistance or from the air temperature, but what we feel as mucosal cooling. And this is coming from the trigeminal nerve. A classic example is the inhalation of menthol. What we found in this study is that when we inhale menthol, of course, we feel a cool sensation. We feel our nose wider. However, nothing is changing in the rhinomanometry results and in the endoscopy findings. Um, Talking about factors affecting the trigeminal nerve function, of course, gender plays a role with females doing better and aging, as the trigeminal system exhibits an age-related decrease, like similarly with other sensory systems. So how can we test the trigeminal nerve in the nose? There is a list of available tests divided in two categories. The second one, below the red line, are more sophisticated. And of course, when you can use, you can avoid subject's response bias. However, they require special equipment like EEG or olfactometer, and they are available only in a few labs across the world. So in my talk, I will focus in the upper part of the slide, starting with the lateralization test. You can see here a device which is a 3D printed in our lab. We ask the patient to identify actually where is coming the menthol odorant. One bottle has a menthol solution, the other an odorless solution. So thus, using a pseudo-randomized sequence of 40 tries, it's nostrily stimulated 20 times, and then the score usually in normal subjects ranges around 35. Of course, we shouldn't forget that history of olfactory loss decreases the lateralization test results. And in general, as seen in many studies, a score of 25 or lower is a red line saying that, okay, below 25 looks to me a pathologic result. Another way is this replication of sniff and stick test. what we use actually in olfaction, we try to replicate it in trigeminal nerve function. It's something quite new. However, especially in the threshold, we could identify quite easily normal subjects from patients with CRS or olfactory dysfunction. Of course, at the moment, there is no large normative data. However, I think in the near future, maybe it will be part of our everyday clinical assessment. Another way is the CO2 pain threshold. This is a replication of a device in my department, replicating what they did in the University of Dresden. So this device had a good retest reliability, and of course, it was quite easy to distinguish control healthy subjects from patients. You see here that patients had a much higher threshold in pain. Last but not least are the taste strips, especially the bitter, as many researchers are using these kind of tests in order to see indirectly the bitter taste sensitivity, which is reflecting actually the solitary chemosensory cells function. So what kind of nasal pathology we could assess testing the trigeminal nerve? Uh, One which is quite new is that the trigeminal function is really decreased in anosmic patients. This is something that we have always keep in mind, and this is reflected in decreased uh, event-related potentials in the brainstem. However, at the same time, maybe you will find increased nasal mucosa potentials as there is a loss of olfactory inhibition of the peripheral trigeminal system. And of course, both of them are coming back to normal when we have a recovery in olfaction. The empty nose syndrome patients are a difficult clinical entity, usually as a result of inferior turbinectomy. And the lack of objective methods to assess this kind of patients is really a problem. What we found in a study done in my department is that these people had much lower lateralization test results compared with normal subjects, and not only had lower results compared with people having inferior turbinectomy, but without ENS symptoms. These results were replicated by the team of Chao, and I think that in the near future, the trigeminal testing, especially the lateralization test, will be part of the ENS assessment. Another kind of surgery with a lot of criticism is septoplasty. In a study done in Thessaloniki in previous years, we found that a significant percentage of patients are not really satisfied in the long term with the result of surgery. Um, of course, this can be a result of failed surgery, but not only that, because everybody knows that we can see somebody with very good endoscopy, with good rhinomanometer result, but there is a mismatch between of what we can see and what people perceive. In a study by Bishop et al., what the authors find is that if you have a good, relatively good lateralization test preoperatively, then the possibility to be satisfied after surgery is much higher. And actually, they measured that if you have a score above 30, then 90% you will have a good result at the level of subjective symptoms. In another study done by the team of Thomas Hummel, what we can keep is that the most significant finding was a decreased trigeminal sensitivity that patients had before surgery. So, in my opinion, we will have to include trigeminal testing in this kind of surgery preoperatively. In CRS, again, similarly, this study found in using lateralization test that people with CRS had lower results than control. And this decrease was more pronounced in the anterior part of nasal septum restored after surgery. Recently, the interest of researchers focused on bitter receptors and CRS. Bitter taste tests have been used as a marker of CRS phenotypes and disease severity. And I would say that mainly authors focused in CRS without polyps, as these patients are more likely to be associated with a non-functional phenotype. In this study, non-polyp patients had a very good correlation with PTC taste test results, meaning that people with a low score had a higher probability to develop biofilm formation. Another study using denatonium benzoate, another bitter taste stimulant, found that in higher concentrations you can easily distinguish people with CRS without polyps, people with CRS with polyps, normal subjects, and more interestingly, at the top, you can find people with aspirin sensitivity. Finally, the non-allergic rhinitis is a really interesting topic related with the trigeminal nerve, as the basis of its pathophysiology is the neurogenic inflammation. So in this study by Van Gerven et al., you see that there is a clear difference in the sensitivity of people with idiopathic rhinitis having obvious potentials at a very low threshold in comparison with the normal subject. And of course, after the use of capsaicin, then you need a lot of concentration in order to have detection of this stimulation. Today, there is evidence in the literature that capsaicin defunctionalizing the TRPV1 receptors could be a treatment option in non-allergic rhinitis. Tomorrow, maybe other substances could deactivate not only the TRP family receptors, but also the T2R family, giving new treatment options. In conclusion, there is no doubt that trigeminal nerve is really important for nasal physiology. We cannot imagine to do a meningeoplasty without an audiogram. However, we do a lot of nasal surgery without any objective assessment before surgery, like rhinomanometry or trigeminal testing. That's why, in my opinion, we should optimize easy methods of trigeminal assessment and then explore new treatment options in order to optimize our therapeutic protocols. So thank you very much for your attention. We will be happy to see you all next September in the next TRS meeting in Thessaloniki. See you soon.